sharing screen. Awesome. And now that we have more folks here, again, if you're just joining us, please drop your name and organization into the chat for attendance. But otherwise, we're going to get started with our guests today from NORC at the University of Chicago. We'll be hearing from Dr. Brett Harris, a senior research scientist, about postvention. And Dr. Harris, I will just toss it over to you. Thank you for being here today.
Thanks, Conlon, for inviting me and for a couple of other members of my team that are on. While we're working on getting these slides shared, I'll just tell everyone that I'm located in New York. And the word for me is anticipation, because we're getting a big snowstorm starting tonight and all day tomorrow. So we've had very little snow all winter, just pretty much ice. So here we can take out the skis and go out for the first time right at the end of February. All right, so this presentation is on postvention, specifically in healthcare settings. Prior to me coming to Newark at the University of Chicago, where I do focus mostly on suicide prevention as well as substance use prevention and early intervention, I spent 11 years working with New York State specifically on substance use prevention and suicide prevention. And then my colleague Gianna is also on this meeting, and she's located in Denver. So we're glad that we were invited to this meeting to share this information. So if you can get onto the next slide, please.
Brett, I just want to double check. Are you able to see the presenter mode, or are you?
Yes.
Okay, let me fix that. Sorry about that.
Oh, it's right the way it is. It's the
okay, perfect.
Yeah.
Thank you.
Yes. And next slide. Yeah. Okay. So I just wanted, I know this is a difficult topic for all of us. So we might have our own personal experiences on this topic. So it's important to take care of yourself. So we just wanted to provide some resources you may be familiar with: the National Suicide Prevention Lifeline, as well as Colorado Crisis Services. So these numbers will give you 24/7 connection to a licensed counselor. Next slide. All right, Gianna, do you want to take it over?
Yes. So as we get started, we just wanted to do a quick discussion with you all using a platform called Menti. So I am going to post a link in the chat box for you all, and you can open this link either by copying and pasting it into your computer browser, or you can scan this QR code on the right with your phone camera so that you can open the link on your cell phone. And then you'll be prompted to a page where you'll see a discussion question where you can type your response in. And when you type your response in just a moment, it will come up as anonymous. So we'll be able to see everyone's response. So I am just gonna stop sharing for 1 sec. While I pull up the discussion and putting the link in the chat box. Sorry about that. Here's the link in the chat box that you can now click, and I will share my screen. And now you should all be able to click that link or open the QR code and be prompted to the question. So Brett, I'm not able to see the chat box, so I'm just curious if folks are able to get in to start.
The link is coming up with an error message for all of us, it looks like.
It's the site, Gianna. It looks like the site itself is experiencing, and their team is working on their site.
Oh no!
Great timing for you. But maybe I'll keep checking it and let you know.
Well, I'm so sorry about that. Technology these days sometimes is not in our favor. So maybe for now, what we can do is we do have the question up on the screen. So if folks feel comfortable typing a response in the chat box or muting for now, and that maybe could be our next best step. So our question we have posted, as you can see, is what have the effects been on your agency, specifically among staff members? And Brett, I don't know if you want to introduce us to this question a bit more before we get started.
Yeah, I will. Yeah, and I apologize for that because more information would have been on the site if you were able to get into it. So essentially, we know that a lot of clinicians have had patients or clients who they've lost to suicide. So we were asking how many agencies had been impacted by a sudden loss by suicide. So the feel free to kind of hand raise or write into the chat. But then we wanted to know what have the effects been on the agency and specifically staff members.
I can talk. My name is Tripti Sharma, and there's different levels of effects, right? There's levels on the individual person or the team that maybe the loss came from, and then the larger effects that it has on the organization. And so, just thinking about that as well. And I see some things on the chat like, burnout, compassion fatigue, all of those things that overall then lead to lower productivity as well.
Yeah, thank you. I was reading some of the chat as well as it was coming through. It's very, it sounds like similar experiences across your different agencies. A lot of compassion fatigue, burnout. It's very difficult for the clinicians in your agencies. So following up on that, if you just want to tell us, what do you hope to gain from this session? And I see Denise's comment in there too. And I think we're only going to touch upon this, like the role of administrators and managers near the end of the presentation. But I think it is, those are really important, important piece that you pull up is that you don't necessarily know everything that's going on as, being in at the administration level, and that there's definitely, steps that you can take and plans that you can make at that level that will help kind of trickle down to the rest of the agency. Great. Yeah, I see a lot of the comments coming in. We're going to try to touch on as much as we can in the hour. And we definitely have more. I would love to, share if we could go a little bit longer, but we do have a little bit more content that we can go into detail about, but we will try to provide an overview of everything. Okay, Gianna, let's continue with the slides.
I mean, like, you'll have it all covered.
All right, so I know that everyone's at different levels of knowledge in different areas of suicide prevention, coming from different areas and fields. So I just want to touch very briefly on what postvention is. And what we've been talking about is that there's often guilt and shame in any kind of following any kind of loss by suicide. So whether it's a clinician or just community members, family members. It can be traumatic, and it can also have a ripple effect on communities. And if we're thinking from the healthcare perspective, from other individuals that are within that health system. It can even be other clients or patients. So the definition of postvention is really, it's interventions for bereaved survivors, caregivers, and other healthcare providers. The goal of it is to destigmatize suicide, to assist with the recovering process, and to serve as secondary prevention efforts. So you may hear people in the suicide prevention field saying postvention is prevention. That's a really critical element. So when we talk about prevention, sometimes we're thinking about things that are more upstream, but after a suicide, there is much that can be done to prevent future suicides because of all of these issues that we're going to talk about throughout this presentation. So the emphasis here is that having postvention plan in place. So essentially timely, coordinated, and appropriate activities that will provide support after a suicide and prevent future suicide. So why would I say have this in place and work on this now rather than in the aftermath of a suicide? It's because to have this process in place at a time when things are calmer and people are kind of working on plans for prevention and protocols and policies versus in the aftermath of a suicide when a lot of emotions and intensity is involved. So having this in place ahead of time is really important. Next slide. Now, specific to healthcare settings, because a lot of the time, in my experience and being in the suicide prevention field, kind of at like a state implementation level for quite a while, is that postvention is usually discussed as community postvention. So what does the community do when a community member has died by suicide? Less attention is paid to healthcare settings, which we do find surprising because we know the burden that this has on healthcare providers. And what we heard through the discussion just a few minutes ago is that most clinicians in the behavioral health field have lost patients to suicide. I've done multiple surveys when I was in New York State of substance use disorder treatment providers, mental health providers. I've seen the research on primary care providers, even pediatricians. And you're seeing at least like, 3/4 have had patients or clients that have attempted suicide. You can be all the way up at a half who have lost patients to suicide. So what happens then? Like what does an agency do? And you can see in this study from 2018 that half changed their practice patterns after a patient's suicide. 1/3 sought increased supervision. 1/4 began using formal measures to assess suicidal thoughts and behaviors, so really changing their policies and protocols to address suicide risk. We have less than 10% beginning to use a formal postvention protocol or a standardized toolkit. And about 10% actually stopped accepting patients they deemed at risk of suicide. So you could see, interestingly enough, like it's not having, the pattern is not great after a suicide to prevent these things from happening, this instance from happening in the future. So only less than 10%. If we want them all to have a formal postvention protocol. And what's kind of alarming is that 10% actually stopped accepting patients they deemed at risk. So what we glean from this is that postvention interventions, they're rare, they're variable, and they're underutilized. And the issue here is that this creates a significant burden on clinicians and the risk of burnout, like we were just talking about. So there's definitely a lack of a standardized approach to training and preparation in the aftermath of a suicide. There are some, we can get further into how to develop this plan, but we will touch upon different things that can be put in place near the end of the presentation. Next slide. So what's critical here, just wanted to pull out in a slide here, is that all healthcare settings should incorporate postvention as a component of a comprehensive approach to suicide prevention. So a lot of times, the focus is if an organization wants to make the effort to really incorporate suicide prevention, they may integrate standardized validated screening tools or suicide prevention interventions. But this is also a key approach to it. It's the postvention plan. Next slide. So I just, the first part of this presentation is going to focus on really what grief is, and then the impact that it has on clinicians. And after we go through that, we can then have a better idea of how managers and administrators can support clinicians in the aftermath of a suicide. Next slide. So I have a traumatic loss up here. So this is specifically referring to suicide, but also could refer to an accidental overdose death. So just using that term, but the symptoms is, intrusive memories about the loss, avoidance and numbing towards it, increased physiological arousal like irritation, anger, decreased sleeping, obsessively thinking about it, inability to shift focus, and also to find joy in life. Also of concern too is when the death is ambiguous. It could be particularly difficult because there could be more intense grief symptoms and unresolved grief. So I think, we do know that sometimes it's hard to actually classify a death as a suicide, and that's definitely, happens most often with an overdose. So whether that overdose was intentional or accidental. So that can be increasingly difficult on a clinician. Next slide. So the term clinician-survivor, so that's for clinicians who have lost patients to suicide. The research out there is showing that 15,000 new clinician survivors of suicide every year. So what is specific to clinicians and opposed to family members, friends, other could be like teachers of a student, co-workers, all of those things. What is specific about a clinician? And so we want to spend a few slides talking about. So these clinician survivors, they often don't have outlets to acknowledge or address the grief because, this is essentially their job. So there's a lot of issues surrounding that concept. So they have no place to mourn, and they also often lack of access to support and grief rituals. There are legal implications like fear of malpractice. All states have their investigations, like Justice Center investigations. So there's that concern. And then there's stigma as well. Stigma is a huge thing in mental health. And with clinicians, medical and behavioral health field, it's a significantly big issue because they're seen as guilty for the death because it was their responsibility essentially to care for this person. Also, they may look weak or unprofessional if they're grieving over this. And of course, they have a sense of responsibility. That was their job to help them. They were supposed to help them. This wasn't supposed to happen. That is huge. And then I was alluding to it a minute ago, disenfranchised grief. That's what we call when it can't really be openly acknowledged. It's not socially permitted because they're professionals. This is their job and it's a professional relationship that they had with the client. Next slide. So 1 in 5 psychotherapists lose a patient to suicide over the course of their career. As many as 1 in 2 psychiatrists. And losing a patient suddenly can be traumatic to the professional, and patient loss is a contributing factor to professionals leaving the field. And I'll just tell you briefly that in my work in New York, we were specifically kind of brought in by our Office of Addiction Services and Support to oversee and license all of the substance use disorder treatment throughout the state, that considering the opioid crisis on top of increasing rates of suicide, that they were seeing significant burnout and turnover throughout the state in their substance use disorder treatment clinics, and wanted to work with us on healthcare postvention. And this is when this became a priority in New York. So this is an issue, and I'm sure it's in Colorado and it's across the country. Next slide. So what's the difference between a typical grief and complicated grief? And following any death, and even a suicide, it is typical to grieve. What does that look like? It's these intense feelings, they lessen over time. In the early months, there are periods of intense sadness. These are normal. The individual is eventually able to return to enjoyable activities and relationships, able to remember the person with less pain after time passes. And eventually they're able to reconcile and integrate the loss. Complicated grief is a little bit different, and those are things that need to be addressed. So the grief in this case, it's intense and it's long lasting. They just feel these longing for the person who has died. There's strong feelings of anger or bitterness, constant fear and anxiety. They have an inability to enjoy things. There's often complete avoidance of situations that remind them of the grief. And this grief can continue for years. They have an inability to enjoy things. They have difficulty accepting the death. And there's impairment in different functional areas, which does impact their personal relationships. And it can be debilitating in significant ways for years after the death. Next slide. So what is specifically for clinicians? Because complicated grief can be experienced by anyone. So specifically for clinicians, there can be, they might suffer increased feelings of helplessness, guilt, as we were saying, a sense of responsibility for the death, diminished confidence in their clinical abilities, being hyper vigilant, not trusting future clients because there are screening questions asked, there's interactions between the clinician and the client, but maybe they left something out, if something was missed, and that's what happened, and that was one of the causes of the suicide, because they missed something. And they get feelings of betrayal. Next slide. There are multiple factors that impact the grief response, and we can talk about professional and personal factors. So of course, there's some of the things we touched upon, the legal and regulatory environment between a clinician and the client, and as well as the organization. The level of care, so if it were inpatient or outpatient, and you can think about the type of relationship and the strength of the relationship, especially in an inpatient setting when there's a lot of time spent between the clinician and the client. So you could see that could really have an impact. The duration and quality of the relationship, and again, that's impacted by the level of care, but also the time that individual was in care. The agency reaction to patient loss, so whether it's punitive or supportive. And that is a really significant piece, especially when we're talking about the zero suicide model, when we're talking about it being an organization-wide approach where suicide prevention is everyone's responsibility, and having the administration really share that with everyone and make that clear to the whole organization. The intensity and demands of the job. So a lot of clinicians we know work lots of overtime, and they also have those on-call hours. So when they're supposed to be off, they could be called at any time. And then the fear of contagion effect as well. And then personal factors. So it could be past or current experience with the death or trauma, beliefs about the role of clinicians in keeping patients alive, like that's a theme that comes up quite a bit. The length of time in the field, or educational or supervisory preparation for death and loss, that's really important. And then hindsight bias, looking back and seeing, what did I miss? Next slide. So what's really important as an organization or agency is that these factors that we're talking about, and losing a patient to suicide, really does interfere with care. And the number one thing we're talking about is patient care. And in order to deliver high quality patient care, we have to take care of our clinicians. So there are a range of responses that can interfere with good care, and it could result in too much of things and too little of things. So for too much, there could be hypervigilance for warning signs. So clinicians could see risk where it isn't at these warning signs. They could, as I said, overgeneralizing and seeing it everywhere. Overworking oneself, so taking on the most difficult cases, really trying to make up for it, trying to do it what they can to help others. Feeling overly responsible for it. Using one's heart, like really feeling that you're in it and you really cared for this person, having strong reactions to it. And then acting overzealous, really trying to, again, it's like the theme is like make up for it and do better and help others. And then there's the responses, the too little responses. Feeling numb to the data that they have in front of them, minimizing or missing risk, missing time, so calling out sick or missing clinical notes, missing supervision, distancing and minimizing impact, being intellectualized and distant and feeling burned out. Next slide. So as managers or clinical supervisors, how do you work with clinician grief? So in the next couple of slides, we're going to go up kind of from managers to administrators. And so this is really critical. How do we put things in place that we can work with clinician grief? So it's really a few things of understanding first, so that grief is not something to be fixed. It's there and it's normal. Just to be supportive, to make sure that the clinician can kind of work through this and be supported and be able to continue with their work and helping other clients like they were helping the one that unfortunately had passed away. Like other traumas, the loss of a person is integrated, but it's not fully resolved. So we need to make sure that we understand that and take into account the clinician's developmental stage and background. So each clinician is different. So talking to that clinician and providing, I guess what I would say, tailored and receptive support is critical. And then acknowledging the enormity and intensity of the grief. So it is a big deal. And we need to understand that, and that it can cause grief responses, and that's normal. And it's also not uniform or predictable as well. The next slide. So what is the role of a manager? And the manager has a lot to deal with in the aftermath of suicide. We need to consider that as well. So it is their role to support clinicians like we've been talking about, but they also have their own emotions too, to manage their own emotions following a suicide. And then it's their responsibility to review the death from an ethical and regulatory standpoint. We know that those are significant issues as well. And then changes have to be made to policies and protocols and procedures. So they're the ones who may be responsible for making programmatic changes. But the key takeaway here is that they are key players in developing and carrying out postvention plans. Next slide. So what are the postvention considerations in healthcare settings? I'm just going to touch on a few things, and there's definitely more here. I think this is really what some of you in the discussion earlier were looking as takeaway points. So a staff debriefing after a suicide is critical, and it should be very soon after the suicide. So it needs to be timely, and we want to prevent misinformation, gossip, and rumors. And not knowing how people are feeling. We want to make sure that we're providing proper support. So the meeting should be short, really around like a half hour. We don't want to go more than that, and factual. So again, not like kind of discussing, gossip and rumor type, but really what happened and what can be done to prevent suicides in the future. It should be including those who were involved, so not a wider group of professionals in the agency, just those who were involved. And then it's important to have proper supports in place for staff. And again, this is why having a postvention plan ahead of time and knowing what those supports are ahead of time and letting clinicians know about them is important, because when this does happen, that these supports are there, that they don't have to be found and provided, but they're already there. So does the agency have an EAP, an employee assistance program? If so, providing that information, and what kind of support do those individuals that work at the EAP provide? Are there trained trauma or grief therapists? Whether it's, in the agency or in the community. Does the organization provide bereavement time? So is there any kind of a clinician take time off afterwards, the rest of the day, or a few days to just to grieve? A lot of times, actually, the bereavement time is rare because the clinicians don't think they can take time off. They just have to keep working after the death. And then what resources are available locally. So it is important to understand what those are, to be able to have that information available for clinicians so that they can access those in the aftermath. Self-care, we hear all the time, not just for clinicians, but for ourselves. And self-care is really critical. So building that time in, just like having morale building activities, that are, I would say, kind of periodically scheduled, having sufficient time off and limiting overtime. We know how, I can say for myself that I just kind of keep working and don't take a lot of time off. We know clinicians are like that. It's just their nature. There's lots of overtime. So if it's like an agency thing where it's like very supportive and encouraging of taking time off and limiting working those extra hours, that's really important. And I just kind of mentioned too that NAMI National does, and this is one of, I'm sure, a few other organizations that really support mental health by giving off a week of paid time off for everyone. So, and really trying to enforce that they don't actually check their email during that time off or work anyway, but it's really showing that they support mental health. And another piece of that self-care as well is shared decision-making. So for clinicians to know that they're part of the decisions that are being made. And like for even in the postvention plan, when a postvention plan is developed, having multiple voices in the development of that plan and having clinician participation would be key with that. And we all know that when our voices are heard in decisions in a larger organization, we really appreciate that. Another key piece for consideration is communicating with and supporting other clients. And you can particularly see this in an inpatient or residential setting where the clients know each other, and this is a loss for them. How do you communicate the suicide? So if you want to think about this from that community postvention perspective, how do you, like when you're talking about a suicide happening, say in a college, on a college campus or in a school, how do you communicate that? And that's really important, rather than kind of trying to hide it, or what is the right level of information at what time to provide that, and what method of providing it. And how do you provide support to clients as well? So again, it's similar to the clinicians in that having resources available like behavioral health and trauma, grief therapists as well, and just being able to provide factual information and support. Another thing is that there are actual grief assessments out there too, like standardized assessment tools, and knowing what those are and having them at the ready to really understand what the clinicians are, what the impact is and how they can be helped. Because if there is like a complicated grief or different feelings of that can result as burnout, to really be able to monitor through grief assessments to ensure that they are kind of managing the grief, and then it does lessen over time. Another piece that actually comes up quite a bit in postvention is what happens with the family members in support of others. So contacting them, and a lot of there's different kind of approaches to this, whether reaching out and not reaching out. It really does depend on the situation, but a lot of times clinicians will want to reach out, provide condolences, even attend funerals or wakes. It's really important to kind of it can be like that kind of support and can be provided, just to make sure that it's not part of the conversation that, you know, I was that person's doctor or counselor, that it's just providing those condolences in a typical way that anyone else in the community, and friend or a family would provide. Next slide. Now this slide brings together some key considerations for both administrators and clinical supervisors. So it is important to make clinicians feel that this is not unusual. So to normalize grief issues, really acknowledging the effect of client deaths on staff members and on clients. And then this is something that's part of the zero suicide model, is reframing suicide prevention as a continuous and coordinated effort by all agency staff members. So no one can feel that they're to blame. And I think we know what happens when we feel that the burden is on individuals, is that we get afraid to even ask about suicide risk. If we identify it, then we need to do something about it. And if something happens, then it's our fault. So, and there are legal implications. So if we can stay away from that, we won't even ask about suicide. And because of that, a lot of patients who may be at risk don't get the care that they need. And suicide is preventable. So it's important for administrators to really acknowledge that this is an agency-wide process, and that it's the responsibility of everyone in the agency and not on individuals. And then it's important to develop competencies through practice and teach back. So this is on a couple of different levels. If we look at specifically suicide risk screening and intervention, that's one for clinicians. It's a very a scary issue, suicide, to be addressing. And there are standard screening and intervention protocols that through practice can be kind of become more routine. So the skills that are learned in the training, it's really important for a clinical supervisor to continually check in about those and really find out how it's going to be able to provide continual support. Then in terms of postvention, that there are managers and as well as administrators really checking in on the postvention plan and to see how that's working and to modify it. So there's multiple ways that things, I guess I would say, need to be revisited periodically and continuously so that they can be improved. I would say, like, in a quality improvement process. And then, so again, helping other managers. So once managers and administrators kind of understand the postvention process, helping them develop clear protocols for traumatic loss and prevention or postvention. So kind of just touching on what we like to do in this type of postvention workshop when there's more time, is to provide training to managers as well as to administrators on how to develop and implement a policy like this. So we talked about the role of managers. So we talked about what staff debriefing could look like, how to support clinicians after a suicide of a client, and also how to provide that safe and supportive environment. There's a lot more detail and steps that are part of that. That is important for managers to learn. So when we talk about training on issues of postvention, a lot of times it is at the managerial level, at the administrator level, because they're the ones implementing this. So there's definitely kind of ways to lead a staff debriefing, different supports to provide, and different ways specifically to interact with clinicians to create that supportive environment. That's really critical, because this is, it's a very difficult time. Next slide. Okay, so we have a few resources here, postvention for healthcare settings, and these are specifically in Colorado. So we have the Postvention Alliance, the Uniting for Suicide Prevention, Rocky Mountain MIRAC, as well as after a suicide loss from the Colorado Office of Suicide Prevention. And on that, you probably have visited that page many times, but it does have multiple forms of postvention. It has the community postvention, but there is a specific part of it on postvention for healthcare settings. So I would suggest checking that out. Next slide. All right, so that concludes the this portion of the presentation, and I wanted to open it up for questions.
Dr. Harris, thank you so much. Oh, Nicole, go ahead.
Oh, yes. Thank you, Dr. Harris. Nicole Johnston, I'm with the Suicide Prevention Collaborative of El Paso County, and we are actually going to be announcing a community postvention plan in March. And we've had recommendations for schools and businesses and community, but this was really helpful. We do have a Safer Care Zero Suicide work group, but this was very helpful information to make sure when we're talking about the community postvention plan. We did have a section with healthcare, but it wasn't very robust, and this helped a lot. So I know Conlon always sends out presentations and slides. We're looking at announcing this March 8th. So Conlon, Dr. Harris, not sure if I can get some of this next week. That'd be great. But just wanted to thank you, Dr. Harris, for the information. It was very helpful.
Oh yeah, you're welcome. And my email's up there. I'm more than happy to follow up or share anything. And Conlon has the slides that he can share. And just like, what I was saying earlier, like, I think that's a very similar thing across the board, is that postvention is mostly thought about in the community. And you would think that there would be more in the clinical setting, but maybe we feel like clinicians, it's their job and they're tough, they go through all this training, and we kind of leave their mental health off to the side. But so more recently, the clinic, what we can sometimes call clinical postvention, has been more front and center. I think particularly now with the in the aftermath of the COVID-19 pandemic, and there's bills, hopefully I think they're getting passed, and about physicians and other clinicians and burnout, and really trying to prevent that. So yeah, I'm glad that you're kind of having this as part of the conversation. So always kind of elevating this along with community postvention plans.
Awesome. Thank you so much, Dr. Harris. We do have a little bit of time here for other questions, comments, discussion. If I could share my slides before the end, that would be awesome, just to talk about those Colorado specific resources. That would be awesome. And then if anybody would like to interrupt with a question or discussion as we wrap up today's learning collaborative, hopefully get some time back in your day as well, feel free. I also just wanted to point out the link that I just dropped in the chat. Dr. Harris brought it up as well, with the Office of Suicide Prevention's website, with a page specific for what you can do after a suicide loss in your community, in your health system, in your school. There's a variety of different breakdowns that link provides, so please do click through those. If I could I share my screen again? Awesome, thank you. I noticed in the chat a lot of folks feeling anxious, concerned, apprehensive, stressed. Just want to, again, express your thanks for being here today and joining this conversation. I know the outside world is a bit concerning right now, and the work that you're doing is so seen, appreciated, and valued. So thank you so much. And Dr. Harris, these resources were amazing. I learned a lot in this presentation, and I hope that it's helpful for folks moving forward with what they have going on with their programming. So thank you so much. I also wanted to flag our academy once more. That will be April 20th and 21st. Today, we actually reached a new record in learning collaborative attendance. Woohoo! So I think in our next session, we will have a Zero Suicide 101 breakout for folks that might be newer to the Zero Suicide framework. We'll have a breakout session walking through each element of the pillars in addition to whatever the main presentation content is. So please keep an eye out for that invite for next time. We always like to flag Operation Veteran Strong, that free confidential resource connecting veterans to resources and peer support, the Zero Suicide Toolkit from the national website, as well as what's available through OSP. I also wanted to emphasize the I Matter Colorado 3 free counseling sessions for youth again. I think I might have seen in an email that got bumped up to 6 free sessions based on the demand from the first time. I can't confirm. I feel like I saw that one time, but regardless, that's a great resource. And then also wanted to flag our care transition resources, as that's an area a bunch of you are moving into with your Zero Suicide work. The Action Alliance released a nice little package of those care transition resources. So please feel free to access that link as well, in addition to the OSP Postvention resources. Also, kind of given this conversation that we had today and the newer folks to Zero Suicide in our state, we will be starting Zero Suicide office hours in March of 2022. This space is going to be really informal. It'll just be a drop-in time where you can come in, talk about where you're at with Zero Suicide implementation, troubleshoot with folks from the Office of Suicide Prevention and others implementing the framework. But especially in light of our conversation today and from what we heard from Resilient Colorado last time, if you need to come in and just chat or be in a space of like-minded folks doing this suicide prevention work, please feel free to come in and have that space for community as well. So that will be starting in March. Keep an eye out with the next Learning Collaborative announcement for the information for that. The Zoom link should be the same, just this personal meeting room of mine on Zoom. So none of that will change. And then again, please feel free to click through these links as you have time. Lots of great resources here. But thank you again, Dr. Harris and the rest of the folks from NORC at University of Chicago. This was very helpful. Our next meeting will be the 4th Thursday of the month in March, so March 24th from 10 to 11 a.m. As always, please feel free to reach out to me to add someone to the list with any questions or suggestions for topics, anything like that. But otherwise, please take 7 minutes back into your day, de-stress, take a step away from your computer, whatever you need. And thank you so much for being here today. It was great to see some familiar faces, but have a good rest of your week and thank you for being here.
Thank you, everyone.